My name's Jon Armstrong. I'm the Medical Director at Advanced Surgical, and the purpose of this video today is to talk about obesity surgery and why we perform the surgery and the two common types of surgery that I perform. We know that obesity is a global pandemic and at least 60% of Australians battle their weight, and probably 15% of Australians have morbid obesity, which is a weight that is extremely high and of great detriment to their health. If you have a body mass index more than 35, it's actually quite unlikely that you'll be able to achieve long-term sustainable weight loss at 5 years. We use surgery more commonly now as it's able to be performed laparoscopically. There are some risks of surgery, but there are significant benefits. Patients who are attracted to the surgery of sleeve gastrectomy, as it is relatively simple to perform, it is a relatively low-risk procedure, and there's extremely good results in terms of weight loss. And these weight loss results appear to be sustained in the long term, i.e. up to 5 years now. One of the advantages of sleeve gastrectomy is that patients are able to have a fairly normal diet. With some other procedures, such as the gastric band procedure, patients are unable to eat steak, bread, and some other fibrous foods. With the sleeve gastrectomy, generally patients can eat whatever they want to eat after 8 weeks, which is an obvious advantage. Another advantage of sleeve gastrectomy is there is no need for adjustments afterwards. It's very much a set and forget procedure, and patients generally don't need to worry about any mechanical problems in the future. It does sound like the perfect operation, but there are a number of issues that patients need to be very aware of before considering sleeve gastrectomy. Firstly, it's a permanent procedure, it's therefore irreversible, and there is a small risk, roughly 1%, of having a leak after surgery. This would be a very significant problem to happen, and generally would expect to occur within the first week after surgery. If patients are well after a week of surgery, then generally we wouldn't expect them to have a problem in terms of leaking from then on afterwards. If they were to have a leak, it could require a prolonged period of hospitalisation and possibly multiple operations to fix up. When we perform the procedure of sleeve gastrectomy, we use a stapler, and this is the actual stapler that we use. This model represents pretty much the size of the empty stomach. The stapler comes in through one of the 1 centimetre incisions and runs along the stomach and then fires several hundred staples along in this direction. As the stapler staples, it actually divides between the staple lines, and then we change the cartridge and go along and along and along to the stomach to the end. And the end result is the stomach is actually divided into two, and 3/4 of the stomach is then removed and physically taken out of the patient's abdominal cavity. The end result is a small, thin tube of the stomach, and there are two reasons why patients lose weight. Firstly, they can only eat a small amount, and secondly, this part of the stomach produces most of the hunger hormones, and when it is removed, patients really do feel a lot less hunger. And it's that combination that gives the good weight loss that we'd expect from sleeve gastrectomy. I've personally performed 750 laparoscopic sleeve gastrectomy procedures. I started the surgery in 2005, and it has become an increasing part of my practice since. In terms of complications after sleeve gastrectomy, I've been very fortunate. We've not yet had any leaks, and I've performed 750 sleeve gastrectomies. We've had less than 1% of the patients who've had to return to theatre for bleeding after surgery, but all of these patients have gone home within a day of their normal expected discharge date. In terms of weight loss, most patients would be expected to lose at least 66% of their excess weight after this surgery. Some patients would lose far more than this. One of the determinants of overall weight loss is how much weight training patients perform after surgery, and we know this is extremely important in terms of preserving muscle mass and also ultimately losing more weight. In terms of patients' medical problems after sleeve gastrectomy, many patients have a number of defined problems prior to their operations, such as type 2 diabetes, hypertension, and problems with their cholesterol, and also sleep apnea, particularly in men. Most patients with diabetes who have this form of surgery would be expected to have much better control of their diabetes and possibly be off all their medications, sometimes within a few weeks. This is, however, not always the case. In terms of blood pressure, many patients have a reduction in their blood pressure medications or maybe off their medications altogether at 6 months. Many patients with sleep apnea will have complete resolution of sleep apnea. Patients who've had sleeve gastrectomy are generally only able to eat a small cupful of food. This is one of the reasons they lose weight, but the other reason they lose weight is they have profound reduction in appetite. And this seems to be sustained for the medium to long term so far. There are several reasons why weight may go on again. Firstly, if patients were to be snacking and not exercising, they generally would be expected to have a pretty efficient stomach, and therefore they may slowly be able to put 1 to 2 kilos a year on thereafter. There's also the possibility that the small stomach may stretch with the passage of time, or possibly make more hunger hormones, and that would promote weight regain. Another possible complication of sleeve gastrectomy is the small possibility of having nutritional deficiencies afterwards. The stomach is involved in absorbing iron, calcium, and vitamin D. Generally, we wouldn't expect patients to get low in iron or B12, but if they were to get low in iron or B12, they'd need an injection of B12 or an infusion of iron. In summary, for the vast majority of patients who are battling their weight, particularly if they have a BMI more than 35 now, they will find it quite difficult to achieve sustained weight loss with diet and exercise at 5 years. Surgery is certainly an option. If you'd like to discuss it with us in a bit more detail, please don't hesitate to contact us. We have 2 secretaries who are quite well informed and will be able to answer many of your queries. We work in a multidisciplinary setting with 3 dietitians and also a clinical psychologist, and we look forward to meeting you at our clinic. Thank you.